Thank you, Chris. It's a great opportunity to talk to you this afternoon, so I'm really delighted to be able to be here. It must be 40 years or more since I first came to Bournemouth to spend summer holiday with my grandmother who lived in Bournemouth, and it confirmed my view as I came to the conference that Bournemouth is always sunny because it's beautiful out there. So I hope that provides the appropriate mood music for our conversation this afternoon, which I think is also important. It is the first time that I've been able to address the plenary of the Alliance. This is a really important conversation for us in the board, to be able to talk to so many of the people making the changes, building the new system out there in the NHS is a fantastic opportunity. For my theme this afternoon, you will not be surprised that I take the words the Commissioning Board and CCGs working together for the NHS and its patients. And the reason that is the right theme for this afternoon, I think, is because these are new organisations. The board, as Chris has just said, is completely new. I've had the privilege of working for both those organisations that Chris referred to. And what is very clear is that the Commissioning Board, just like CCGs, is specifically here for one purpose and one purpose alone, and that's to improve care and outcomes for patients. And so that is a major mission for us and a worthy topic of conversation this afternoon. Before I get into the opening of where we are, it is absolutely incumbent upon me to thank people in this room for the immense amount of work that's underway at the moment. The last period has inevitably seen the NHS subject to immense scrutiny and commentary, and despite that scrutiny and commentary, and despite continuing to do the day jobs that many of the people in this room do, which are demanding and important for patients, we have seen phenomenal movement and improvement across the country over the last few months. So I think my first point, is well done, thank you, and please keep it up. In terms of where we are, I think it is absolutely right to talk at this particular point in time. We've very recently had the NHS Commissioning Board mandate issued by government. And that, I think, is really important for us, potentially, I think, for you as well, in that the mandate is a new kind of relation. It underpins a new kind of relationship between the NHS and government. It's our settlement with government about how the delivery of a publicly funded healthcare system in this country takes place. It represents, I think, genuinely a significant step for the NHS to ask a new organisation to take forward the NHS in partnership with other bits of the commissioning system, and in particular CCGs. To move it away from Whitehall in that sense, I think, is genuinely new. And what's also important about the mandate, I think, is it has two fundamental underpinnings, which I think we need, certainly in the Commissioning Board, to see as the basis of everything that we are doing. The first is the NHS outcomes framework, with which I'm sure you will be really familiar. Making outcomes for patients better, and doing that across the various domains of the outcome framework, from preventing people dying prematurely right through to helping people have an enhanced quality of life if they have long-term conditions. The full gamut of care, focusing on improvement for patients is an important element of our mission, and one we take really seriously. The other thing that we're absolutely charged to take forward on behalf of the NHS in England is the NHS Constitution, a statement of rights that NHS patients in England have access to as part of the deal of being a citizen in this country. So I think the mandate for us is important, not only because of the constitutional consequence, the sense that it's part of the handover process to a new and much more independent commissioning system in the NHS, but it's also important for me in thinking through our role as a commissioning board and the rest of the team there, led by David, in reminding us what we're here to do, to ensure that patients get good outcomes and the rights of the NHS Constitution are everywhere applied all the time. So I think that's, if you like, the mandate, and I think it is really important. It is an important point of time. But the fundamental importance of the mandate is that it reflects the sense that it's over to us now. So there's been a lot of conversation, obviously, in the political process. We've all watched that over the last couple of years. There's been a lot of work in the preparatory process to get to this stage. The mandate does now represent the passing of a baton to not only the commissioning board, but absolutely to the people in this room. It's now absolutely up to the commissioning system, CCGs as lead local commissioners, and the commissioning board as a commissioner of services in its own right and as a national support to make it happen. And it's also, I think, important to talk to you now, not only because that's the baton passing that I've talked about, but because now's the time when you and we are all turning our minds very strongly to how we plan for year one of the new commissioning system. At this point, I often talk about planning. And at this point, a sort of unknown groan goes up from the audience. So I shall spare you the 1 hour talk on the minutiae of a planning system and instead move up a level. We are talking about planning. I know you're talking about planning. That's not because we're just interested in the technicalities of planning, though, sad person that I am, I probably am, but it's actually because planning is about patience. Planning is no more and no less than the means by which we as commissioners, and probably you as commissioners, make good things happen for patients. And shortly we will be producing the fruits of the work we've done with CCGs and other stakeholders, but particularly with CCGs, on a new planning system for the health service. We start in a good place. The legacy is good. In general, there's a good financial position, and absolutely importantly, we've seen great things happen for patients across the country in many, many places, whether it's access, safety, or other domains of quality. But we're absolutely clear that the old planning system was designed for a world of significant revenue growth and growth that enabled activity to rise and targets to be met. I have to say that, as we all know, is no longer the order of the day, and consequently we need a different planning system for the NHS. Importantly, we also need a planning system that builds on the really exciting things in the reform programme. So what you will see is a planning process that genuinely values local clinical priorities. A planning process that absolutely wants to ensure that the NHS constitution is delivered, but that is about local decision making as much as it's about the constitution and the national ask. We're really serious about that, and I look forward to discussing that with people in this room further. In making that happen, making a planning process that allows CCGs in particular, working with the support of us as a fellow direct commissioner, but nonetheless leading the conversation locally, to really identify and focus on local needs. I think there are some big issues that we need to think through with you, and we are doing so already nationally, and look forward to that conversation locally about how in this planning round, year one of the new system, we avoid a whole series of what I would describe as false trade-offs. So it's very easy to describe where we need to get to next year, certainly from a commissioning board perspective, and I suspect it may be the same for CCGs, from a position of easy polarity. So do we want stability, recognising the system is new? We are a new commissioner of services. We, as the commissioning board, will be taking on new responsibilities. Today we're talking about specialised services and writing to the chief execs of all hospitals that provide those about the way we will do that. So do we want stability, or actually are we impatient for change, for improvement, for driving things forward for patients? Well, of course, I would suggest both those things are equally true. So we need to avoid a sense that we can't do both at the same time. Equally, given the situation that we all face about making sure that we drive improvement while making sure that financial sustainability is achieved, I don't really buy the argument that we either sort next year out or we sort the long term out. We just need to do both. And importantly, and again, I suspect I'd be rather surprised if this doesn't come up in the conversation later, I think we do need to move on from the debate about local versus national priorities. The new planning model absolutely will recognise and incentivise through the structure of the process a way in which local priorities can be identified and can be addressed. We will be looking to be part of that conversation because we do commission primary care, specialised services, we're members of health and wellbeing boards. We're absolutely not in that conversation as a judge. We're there to talk about our contribution to the work that you're doing on behalf of your patients locally. I hope you will see that as a real plus point. In addition to that, the planning process will also obviously talk about the conversation we have with our own providers of specialised services and the conversation we have with you building on the authorisation process. But I'm absolutely clear that the local element of planning is really important to us, and I look forward to you seeing that when the documents are published, alongside the allocations, which I guess you may be interested in as well. So I think that's the next big thing for us, the planning process, but it's really important to put that in a context of where we are at the moment. So everybody in this room is working through how we drive forward improvement while also improving efficiency. That is the expectation on all of us. We've all worked in the system for many years. You know, there's thousands and thousands of years of expertise in this room, I'm sure. So people are experienced at this. Therefore, everybody in this room will know that back in 2008-9, it became evident that the historic resource base that the NHS had enjoyed, up to 10% growth, was not going to be available going forward. Now, I know everybody in this room shares my view, absolutely, that the new financial environment is there and that it absolutely needs to be addressed, but it can't be at the expense of not driving forward improvement for patients. I don't see those as a trade, as I talked about before. I'll come back to that in a minute, but before I do, I think it's worth just taking a step back and also reflecting on the need for profound change. So if you take non-elective demand in the health service in England, we've moved from a situation where a year ago that was on track. The plans that PCTs had with the support of primary care commissioning as it was emerging at the time looked like they were coming to pass. This year, we've seen activity move ahead of plan by around 3.1% so far. Now, in some senses, what does that tell us? Well, it tells us, we've got to plan differently. More importantly for me, it tells us that we've still got patients who are getting a response to their urgent care need, which is, I'm sure, of high quality as a response goes and provided by caring and dedicated professionals. But it absolutely tells me that the way the system is configured is still not right. I'm really interested in ensuring that where somebody needs to go into a hospital as an urgent care response, that hospital is there and it's good. But I don't think there can be anybody in this room that believes that that's universally the case and that we can't do better by organising services differently around the needs of patients. So for me, that's what planning is about. We all know in this room that we've got real opportunity to reprofile care. More importantly for me, CCGs, I think, are now driving this and clearly have some really positive ideas about moving care out of hospitals into community settings, finding ways of innovating, integrating services that currently are fragmented, all the stuff that's the daily conversation of CCGs as they look ahead to the future. I think my sense is that as I go around and talk to people, people are really focused on this, and that's really positive. My other sense, though, is that we between us as commissioners, but us also in support of you as clinical commissioners in CCGs, we have to think carefully about pace here. Because if we are saying stability and change are false trade-offs and we need elements of both, we absolutely do need to look at the pace at which we redesign services around patient needs. Now, I'm well aware that redesigning services is tough and often leads to contention. One of the messages I do want to give you today is that the board is, at least in part, here to support you when things get tough and if things get tough. So through our local area teams, we will be there to work with CCGs, not in a sense of direction, but absolutely in a sense of support, where the case is being made for improvement and change that drives forward quality of care. We will be there to support clinical commissioners make things happen. That segues me, I think, into where we are on clinical commissioning, and I know Barbara talked about that this morning. My sense is a huge amount's been achieved. I think the 211 CCGs have made vast progress in recent times, and I'm very, very aware that that's taken huge amounts of time, not least of all from the people in this room. I think the initial signs are that the authorisation process is being well regarded, and I'm really pleased about that. I was privileged to be able to sit in on an authorisation visit as an observer just last week, and it was fantastic to be able to listen to local clinicians and stakeholders talking about how they were working together to really identify the needs of the local population and what they were going to do about it. So I think the signs are good. I am very hopeful that the basis of authorisation will provide us a really good basis for working forward with CCGs. Because I think we do need to think about how accountability works in the new system. And in particular, the role of the Commissioning Board and CCGs and the interaction between the two. And I think, picking up on Chris's earlier point, this is distinctly different. There is a very clear vertical line in the current system, in the old system, Department of Health, SHA, PCT. That's a linear relationship to a large extent. We are aiming for something completely different this time. And something different because we need to reflect the different roles that we have. So I said before that the NHS Commissioning Board is there in every community in the land. We will be commissioning for primary care. We'll be sorting out specialised services. These are important services for local people. We'll be in health and wellbeing boards. We, I think, look absolutely to work in partnership as equals with CCGs in that relationship. There's not a hierarchical relationship in sight there as far as I'm concerned. That, I think, is critical to allow us to focus on local priorities that we need. In addition to that, we are commissioners in our own right, and we have the relationship with providers that I talked about earlier. We're talking today about how we move to a new model of commissioning specialist care. We want to absolutely ensure that the commissioning we do of specialist care is lined up with the local commissioning that CCGs do, so that patients get an integrated deal. And in relation to the duties that we do have, the statutory duties we do have to make an annual assessment, we very much want that to build upon the process of engagement that authorisation has created. So my first question is not, why has something gone wrong, but what can we do to make things better, and can we offer support? Obviously, we do have an assurance role, and that will be there. But the mindset we approach this with is absolutely clear, and one based around an aspiration of success and our mission to help clinical commissioning be as good as it possibly can be. I don't see that this is a soft option. I think this is a really important option. There's accountability built within that, but it's accountability deployed for a purpose, and an accountability that doesn't default to inappropriate judging and criticism. Equally, there's mutual accountability built within this system, in my judgment. So I very much look forward to continuing discussions at the local level about how we discharge our commissioning responsibilities. If you think about the importance of improving, let's take an example, primary care provision. We know, don't we, in this room, that getting primary care into a state that builds on its current success but reflects the changes that we need in care elsewhere in the system, that localises services, that builds around primary healthcare teams, that looks at quality and improvement, that reflects on the fact that 90% of patient contacts, I think, still take place in primary care. If we can work together on that, us in our direct commissioning role, managing the contract of providers, and CCGs in their lead role for taking forward improvement in the patch, then I do believe that good things can come from that, will come from that for patients. So I think there's a real opportunity for partnership there, and within that partnership the commissioning board is very comfortable indeed to be held to account by CCGs for the way we discharge our elements of that. We're absolutely up for mutual accountability. Because beyond professional knowledge, experience and skill, the real test of how we make this work relates to behaviours and values. By getting those right at the local level, then good things will happen for patients. And that's the reason that if you think about the structure of the commissioning board, the operations directorate that I'm responsible for is the biggest bit of the board, and it's the biggest bit of the board because we are a national organisation, but one that predominantly has a local reach. We are in local communities. We are there to be on first name terms with local leaders of CCGs as people working together to improve services for patients. And that's the point of it. That is the point of it. And that is about getting alongside people, supporting them, working together for common benefit. So, I think the board is determined to get behaviours and values right. I believe strongly that we have worked really hard to try and make a start of what will be a long road working together, I am sure, that was an appropriate one. And so if you think about how we have worked hard to involve CCGs in things like the recruitment of senior staff, sitting on panels, being part of that selection process, to really important conversations we're having with CCGs about how the new system is developed. Phenomenally successful commissioning assembly last week in Doncaster with large number of, I'm sure the people in this room present, really getting to talk about some of the big issues. What happens after authorisation? How do planning work? What about allocations? Where are the difficult choices there? How do we manage the assurance process in such a way that it's a positive experience and leads to further success for patients? Those were the conversations we were having, and those are the conversations we're determined to keep having with the people in this room, because by doing that together, we're far more likely to get a good outcome. So I think if I was marking my own homework, I would, and I'm sure you will mark it for me, and I welcome that, I would say we're trying to start as we mean to continue. We are very new as an organisation, but we're absolutely committed to doing this because we believe it's the right thing for patients and the system. The next few months will be absolutely critical in turning these initial moves into embedded joint working. As we build our structures, which are moving forward rapidly, you know, by the end of this year, we will have our people largely in place across the whole of the country, and they will be out there talking to you, engaging with you, as I know in many parts of the country they already are. So, we're with you on this journey. We're here to help. We're here to jointly work with you for the improvements of patients. In conclusion, I guess I would sum it up by saying that I think for commissioning in this country, there is now a vital mission to steward the NHS to a great future, to ensure that it can deliver the very best quality healthcare for our patients, remains clinically and financially stable, and continues to be a force for good in this country. So whether as clinical commissioners or as leaders of the NHS Commissioning Board, I think that is our key purpose. We really are in this together. I know it's going to be a challenge. Tough decisions will have to be made. But I think it's an incredibly exciting time for the NHS, given the talent we've got in this room and the commitment to make things better. I really look forward to working with you right across the country, as well as nationally, in making this happen. Thank you very much indeed.